Hello, today I am going to present you the process of change implementation of mobile health. Healthcare communities had witnessed many improvements by implementing different changes to improve the delivery care quality. mHealth is one among those changes which is used to emerge area to enhance the access to healthcare. In this presentation, I am going to elaborate the change management process of switching paper-based healthcare into mHealth in a rural region of India. This presentation will cover introduction to mHealth, health intelligence data, steps in change management, risk and conflict analysis and management. Bihar government initiated a change in the traditional way of work in those rural regions by using mHealth. This change was done with the partnership of Care India as a part of Ananya project. Despite of impressive gain in many health indicators, access to quality health care in rural regions of many states of India like Bihar, Uttar Pradesh and others is limited. Bihar government initiated a change in the traditional way of work in those rural regions by using continuum of care services. mHealth, an information communication technology enabled tool, was used to strengthen the health care and improving the quality care of maternal and child care. Why Bihar? In 2006, the district was named among 250 most backward districts of India, and in 2013, Government of India identified the district as one of the high priority districts to promote reproductive, maternal, newborn, child and adolescent health. The district has some of the lowest achievement in terms of health indicators in India. CCS mHealth is a suite of mobile applications with multi-modules that have been built upon the Integrated Family Health Initiative. This change project is aimed to provide holistic care to women and child based on unique need in respective stage of pregnancy, delivery, post-delivery and newborn care. This application have 5 primary mobile forms and link to each stage of the care. The change management process had multiple stakeholders, example, health workers, patients, health managers, health insurance companies, employee, pharmaceutical firms, non-government and government organizations. The change was a well-managed change which is done by multiple research and literature review associated with a pilot study of 2 years. Both external and internal trigger sources were identified. Examples of external triggers were politics, government policy, supply and demand and population trend. Whereas internal triggers were multiple limitations to traditional way, lack of supervising support, research result and technological advancement. The project used Lewis model with a concern-based change management approach. The model was employed as a structured change process through a series of steps. In unfreezing step, identifying the development of new policies and procedure was done, but the focus was on bringing the new technology and the moving stage. In the change stage, implementation of 2 years of pilot studies associated with analysis and management of risk and conflict and mitigation of negative feeling by providing support. Whereas in refreezing stage, permanent implementation is done after 2 years of pilot studies. A tailored mobile application was implemented after comprehensive evaluation of third-party companies. There are few strengths and limitations of the model were identified. Change project was a complex change. Healthcare setting which is considered to be a complex adaptive system, this model provides an opportunity to mobilize neutral creativity of health worker to adapt to the circumstances and evolve new and better way of achieving quality key into bottom of change. Model identify key feelings and experience of the people moving through the change. Literature showed that model as valuable in support smooth transition. Change model is adopted and associated with sufficient flexibility and tailored to empower local level change agent. It may support the complement improvement. While talking about the limitations of the model is not detailed enough. Few steps of quarter 8 state change model was identified in the implementation process. For example, frontline workers were engaged and motivated to celebrate quick wins. The model was too rigid and does not reflect modern timing. Freezing behavior which need to be get unfreeze again. Example, mHealth, the application is made offline for the adaptation of multiple challenges faced by the community worker and this change was freezed. When there is need to update or advance of this technology, the entire project will undergo refreezing. Force field analysis of this change shows both resisting and driving force. Degree of resistance is normal as the change is stressful and bring anxiety among the people. Culture was ingrained and people were not willing to go under the change. Uncertainty among the employees that was change will bring. But resistance force was less as compared to driving force and leaders and managers were successful in reducing the resistance force during the pilot implementation. Risk management was done by following the steps of identification, analysis, prioritizing, treatment, and monitoring of the implemented risk management. Risk analysis was done during the unfreezing stage prior to creating new rules and policies, and risks were managed during the pilot implementation period. Multiple risks were identified, but the three main risks were categorized as risk associated with the finance, as the project was implemented on a very big scale, risk related to device, as it was the main and most important part of the change. Lastly, the risk associated with the primary and secondary stakeholders, example patients and the frontline workers. Risk related to device was device malfunction, misplacement or loss, application usability, network access, sharing of the mobile device. In terms of stakeholder, risks related to frontline workers are adaptation and sustained effective use, as the frontline workers are of different age and different education level. Risks of data security and privacy, cultural barrier between frontline workers and patient. In terms of patient, reliability on healthcare workers provided information, as with limited remote supervision, tendency of frontline worker to lead to wrong information. Risk was managed by mitigating, sharing and reducing the impact. Financial risk was mitigated by including multiple partners, example Bills and Melinda Gates, and receiving donation. Risk related to mobile application management is done by partnership with professional and experienced Dimagi. In terms of mobile related misplacement network issue, mobile kunji, card based replica of mobile application was provided to frontline workers. Similar to risk management, conflict was managed by identifying, analyzing, prioritizing, treatment and monitoring of the conflicts. Both constructive and destructive conflicts were identified during the different stage of change management. In terms of constructive conflicts, incompatible working style, poor communication, heavy working style, personality clash, stress and fatigue was identified. Constructive conflicts were avoided to get solved with time. While talking about destructive conflict, it is divided into three parts: individual, interpersonal and organization. The examples are prior to change, conflict due to learning or survival anxiety, conflict between patient and healthcare worker, multi-voice arises from diverse form of stakeholders' opinion. During change are clash between two different teams of ASHA and AVA, system-based barriers. After change is conflict between traditional and innovation ideas, conflict between real and pseudo team, and task-based conflict. All the conflicts were managed by using different style. Task-based barriers and conflict between real and pseudo teams were solved by using collaboration. Conflict between traditional and innovation idea was compromised due to multiple risks which were associated with this. Most of the individual conflicts and constructive conflicts are avoided. Interpersonal and organization conflicts are managed by accommodation. A good example of accommodating conflict management is proper supervision network was built and leaders of different levels was assigned to supervise remotely working frontline workers on daily basis to monitor the risk and conflict management. Data transfer between ASHA and AVA was maintained. The change is implemented in 35 sub-centers in Bihar in 2014 with 550 frontline workers supported by 58 supervisors and 12 managers. Although the change program was a perfect example of well-managed textbook change management program, where all the parts like conflict and risk were well identified, analyzed and managed with combination of evidence-based research and literature-based framework. But there were few points which could have been done better. In this change program, lack of role of leaders were seen. In turn, according to literature, role model leadership style is considered more beneficial in community-based change program. Most of the leaders and supervisors were managing the staff online and there was less evidence of local or on-ground leaders. Identification and engagement of local champions were much needed to motivate the frontline workers. Lack of evidence of involvement of frontline worker in decision making. Literature suggests mHealth should be designed and implemented in a participatory manner. Implementation of the mHealth showed great emphasis on dependency of the technology rather than on individual. Knowledge of experienced frontline worker could have been used to enhance the framework of the implemented change model. To conclude, mHealth is definitely a much needed boom for improving the healthcare delivery, especially in rural regions of developing countries. However, the risk and conflict in the path of the change process need proper consideration of all the possible outcomes via different modes like research, literature review and pilot studies, and finding a solution to all the potential and actual challenges.